with COVID, that's probably been a prime example. We've had quite an increase in the prevalence of patients presenting with poor workstation setups. Ambulance officers are exactly the same. If they are working in a call centre, they may be sitting for, say, an 8 to 10 hour shift, sitting for a long period of time. So making sure that their workstation is set up well, is imperative to decrease the likelihood of an episode of back pain or neck pain or, wrist pain from sort of, acute RSI stuff from typing or using a mouse. Yeah. Definitely that's something else to think about, which we probably don't automatically sort of jump straight to. We always think of the acute events, but, if you're sitting in an ambulance, making sure the car seat's at a good height for you as well. So there's lots of different sort of avenues that, we can work on to try and decrease the likelihood of developing pain.
Well, welcome to the podcast, everyone. Today we are talking about something absolutely crucial to not only living a healthy life, but having a long and successful healthcare career. My guest today is Erin Moss. Welcome to the show, Erin.
Thank you for having me, Ben.
Yeah, it's absolutely our pleasure. Erin is a managing partner and senior physiotherapist at Allsports Physio. Let me just give a brief bio for Erin before we jump in. In 2012, Erin attained a Bachelor of Physiotherapy with honours and a Bachelor of Exercise Science. Her honours research focused on identifying risk factors for musculoskeletal injuries in athletes. She now runs a full clinical list at Allsports Physio, treating a variety of conditions ranging from lower back pain and neck pain to acute sporting injuries and work injuries. Erin has run a half marathon just to appreciate the athletes that she treats. And then in 2019, she was named Young Partner of the Year for the Healthier Group. Erin, it's absolute pleasure to have you on the show, and I can't wait to get into this sort of stuff because this is critically important for those, particularly or anywhere on the where they are in their career, their healthcare career, but particularly at the start to set them off on the right trajectory, because prevention is better than cure. So thanks for coming on the show. Yeah,
my pleasure. No, I absolutely agree. I think it's fantastic that you guys are offering this service to your students. Like, it's great to kind of, for us to even to get our message out there, beforehand, to try and set people up for a really good and healthy career. So I really appreciate your time, and thanks for having me on.
Absolutely. Absolutely. Our pleasure. What do you love about what you do?
Oh, I've got the best job in the world. I think I'm hoping some of the students can identify with this as well. But anyone that gets into healthcare does it because they want to help people. So I've got a fortunate job that I can actually do that every day. So our main goal is to help our patients to achieve their goals, whether that be sort of to decrease their pain or to get them back into whatever it is, whether it be a work or back into their sport. I get to do that every day. So I love it. I sort of see a range of patients, as you said. And so each half an hour, I've got a different patient on my table, so a different conversation, and you get to know people really sort of well through that. And it's just one of those really rewarding careers. So I'm very lucky. I love it.
Awesome. Well, we know of some paramedics and some emergency healthcare workers that have enjoyed your support and treatment ongoing and with injuries and things like that. So and what experience have you had with supporting and treating emergency and healthcare workers? Yeah,
so I guess being in a private practice, we do see a whole range of people, and you're right, I do see a few emergency care workers. So I've got a couple on my list that I've seen sort of, some just occasionally for a specific episode of an injury, but some that are sort of more that sort of long term. And I guess, my experience with that is basically, seeing those patients and just trying to get them back into whatever it is. I have had some QAS ambulance people as well, and we treat people under work cover as well. So if they've got sort of some workplace injuries, we try and manage them and sort of work within sort of the QAS system or private paramedics to get back into whatever it is that they need to be doing. So on that sense, I've seen them clinically. We're located right near GCUH, so my practice is at Parkwood, so just right up the road, a stone throw away from Gold Coast University Hospital. So not only paramedics, we do see quite a number of different healthcare workers as well that sort of come to us, which is great. on the flip side as well, like I've also worked with paramedics. Previously I've done some acute sporting injury management. So part of our role sometimes is to actually work within the sporting community. So I was the head physio for one of the QAFL teams for a number of years. So occasionally, you get those injuries that needs a paramedic assistance. So knowing that we can call the paramedics and they'll be there very, very soon is excellent. So our job, I guess, with that, just thinking for some examples, having some nasty compound fractures and some spiral fractures and things that we kind of, immobilise and then just wait for the paramedics to get there and get them off to hospital. So on that sense, we work with them as well.
Excellent. Yeah. Your experience is really important, I think, for this discussion, because we're not only going to talk about, the health of the healthcare worker, all right? And you're obviously experiencing that in your practice at the moment, but you've also done the events, the sort of first response physio. So we're not only going to talk about how the risk factors for injury for healthcare workers. We're going to talk about the treatments. We're going to talk about how to prevent injury, but we're also going to talk about how we better care for those we're caring for in an emergency. So, so it's really good angle. So I'm really looking forward to jumping in.
Me too.
Awesome.
Yep.
All right. Erin, can we dive into now, what are the most common injuries that you have seen in healthcare and emergency care workers?
So it's a good question. I definitely say that lower back pain's the most common injury that we see. And again, only due to the fact that it's actually the leading cause of pain and disability worldwide. Most people will experience low back pain at some stage of their life. So, it might be sort of the overall sort of grumbly sort of low back pain that kind of stays there, or they may have an acute episode or an acute flare. So I guess people generally present when they actually have an acute episode of low back pain. So you might have heard people, common examples are, going to the gym and lifting something heavily and sort of feeling their back spasm type thing. That's quite often when we see them, and I have had a couple of emergency care workers that have come in with those types of things, more related to actually moving patients. So they've sort of suffered an acute flare-up when they've been manual handling a patient, because let's face it, patients are heavy, especially the really sick ones, if they can't actually help, mobilise, and you have to do all the heavy lifting. So that's probably the most common thing that we've seen. And again, people come in and they quite often will settle in about 4 to 6 weeks, but we can kind of help to support them during that time and kind of get them back into things a little bit quicker. So to decreasing their pain, improving their function, and just trying to get them back to work and out of pain as soon as possible.
Is this sort of career, would you say, a high risk career for manual handling? Where does it sit in the sort of risk area?
Yeah, again, it's a good question. I guess, we do see a range of different people from a range of different career paths. Probably with the paramedic sort of field, I guess patients don't always conveniently, fall to the ground in a nice open space. There quite often is, lots of obstacles out in the way. If you're having to do CPR, or it might be in the patient's own home or out in the community. So it's not always a very convenient place for a patient to be located. So paramedics definitely do have to work within their environment to try and sort of manage the patient and also themselves in that situation. I guess, and I was just having a look at your setup out here, and you've got those sort of the striker, the stretchers, which are excellent. And a lot of those are sort of semi-automatic or automatic, but there are some that are still manual. So they might be, say that the stretcher's got a 100-kilo person on it, that you might be having to push and pull that stretcher over uneven ground to sort of get them into the ambulance itself. So there is those types of things that, again, like any job that's got that little bit of manual handling or heavy lifting, I guess it does sort of place you in that sort of higher risk category. The other thing I have had a patient before who he'd actually hurt his shoulder, so he was carrying the ECG machines, and so they have to take them to patients, obviously, that are having cardiovascular events, and they weigh 13 kilos, so they're quite heavy in their own right. Yeah, right. So the equipment that you guys lug around is quite heavy. Right,
so it's the equipment, it's the patients. I'm assuming that there would be some injury events, as well as some ongoing issues build up over years of doing, repetitive tasks, sitting, whether it be in an ambulance or even in a call centre.
Yeah, that's a good point. And sitting for long periods of time is certainly one of those things that it can lead to overuse injuries. With COVID, that's probably been a prime example. We've had quite an increase in the prevalence of patients presenting with poor workstation setups. Ambulance officers are exactly the same. If they are working in a call centre, they may be sitting for, say, an 8 to 10 hour shift, sitting for a long period of time. So making sure that their workstation is set up well, is imperative to decrease the likelihood of an episode of back pain or neck pain or, wrist pain from sort of, acute RSI stuff from typing or using a mouse. Yeah. Definitely that's something else to think about, which we probably don't automatically sort of jump straight to. We always think of the acute events, but, if you're sitting in an ambulance, making sure the car seat's at a good height for you as well. So there's lots of different sort of avenues that, we can work on to try and decrease the likelihood of developing pain.
Yeah. All right, awesome. We're going to go a bit further into prevention techniques a bit later, so that's going to be interesting. Obviously, we don't want to know just about what injuries we can get. We want to know how to prevent them. You've mentioned lower back pain as maybe the number one. So what are some of the other injuries that you see coming through from healthcare workers or similar injuries, similar workplaces?
Yeah. So definitely neck pain was one, and that was the example that I'm thinking of was actually a call centre worker. I actually think she was to do with the fire brigade as well. So they do similar type things. So they're manning the phones and with sort of multiple computer screens in front of them with dispatch. So that's definitely one. I have seen an ambulance officer actually who unfortunately did quite a high grade ankle injury, and that was just bad luck. It was sort of walking on uneven ground, and like other people can, or normal people can, or on the sporting field, if you sort of step into uneven ground and you come over on your ankle, you invert it, and that puts stress and strain on usually the lateral ligament complex. So that was another one that was just an unfortunate injury from an ambulance officer.
And that's an interesting point too. In a sort of a more confined workspace like an office, we can sort of optimise our work health and safety components of that environment. But as an emergency worker, you're going out to a situation where you're going to have to assess that risk yourself. You've never seen most of the places you're going to before. So there's that really critical element of being able to assess and continually think about your own health and safety and where the risk is.
Yeah, definitely. And I guess too, with the mental health component as well, quite often ambulance officers are sort of attending, sites where, there might be some mental health patients. And, we certainly see that in the hospital system as well. Quite often they may be at risk of assault, from their patients as well, or patients that are drug affected or alcohol affected, or not in their sort of normal frame of mind. Again, it is just a bit of a risk, and people just need to make sure that they've got their body in the best possible position to, stay away from that type of injury as well.
Yeah. All right. So in your experience, have you seen, whether in the research or, the people you see, what are the risk factors for increasing somebody's potential to injury, or where the injury occurs itself? So is it age? Is it genes? Is it the type of build that somebody has, or even is it their fitness level and things like that? Where does the risk lie?
Yeah. Okay. Yeah, that's a good question. I guess, unfortunately, as we get older, there's often things that, we sort of start to develop these normal age-related changes. I guess, for example, with low back pain, if we were to do an MRI scan of someone's back from the age of 30 and did that every decade, up until the age of, say, 90 or 100, we would start to see changes within those images. Again, like getting grey hair, these are normal age-related changes. And I guess just to go on a bit of a tangent there, low back pain is probably one of the biggest things that is unnecessarily scanned. So quite often, patients come and they go, I've got a disc bulge, I've got a disc herniation, and they've sort of haven't had an acute episode, but they've just got some, grumbly low back pain. And again, that's a normal age-related change. So we can't pin everything on the normal things that we would usually see. Similarly, like around the shoulder, our tendons start to get older as well. So we start to see sort of tendon changes, so tendinopathy, rotator cuff tendinopathy, which again is normal and doesn't necessarily sort of correlate with level of pain or dysfunction. So I guess, we can't blame our age for everything. I guess statistically, you're more likely to have an injury the older you are, just because you've been around longer. So you've been working for a longer period of time, or you've just been on this earth for a longer period of time. So that, I guess, probably age, yes, is a risk factor, but just because from a statistics point of view, you've just been here longer. I guess too, genetics, there are certainly some injuries that there is a genetic component, but we actually can't change our genes, and so we can't blame our parents for everything. So we're probably not able to really modify those risks. So if we talk about the things that we can modify, definitely physical activity is one of those things. So we know that the more active that you are, or at least sort of being active every day, decreases the likelihood of persistent pain. So one of the biggest things that we can do is just move our body. As we were talking about before too, if you are, say, for example, in an office or sitting at a call centre and you're sitting for 10 hours a day there, don't go home and sit for another 5 hours in front of the TV, when you get home. That's sort of 15 hours per day of sitting. And, we know that sitting's the new smoking. So if we can avoid sitting as much as possible and actually just get out and move our body, we know that the likelihood of something, so specifically low back pain, will definitely decrease. I guess people quite often think about, having a strong core, in terms of decreasing the likelihood of injury and low back pain. I guess, weightlifters quite often talk about their core and how to lift properly and activate your core. And I guess when physios talk about core, we're actually not talking about your six-pack muscles or the big muscles that run up either side of your back. We're more talking about the deep muscles to those. So things like your pelvic floor, which is sort of the sling of muscles that sits on the bottom of your abdomen, your transverse abdominis, which are the ones that wrap around sort of your trunk, and then your multifidus, which are tiny, tiny little muscles that only span the width of one vertebrae. So all of these muscles, they tend to switch on in a normal population that's asymptomatic. They have a little bit of tone throughout, which is just normal. If someone's got back pain, for example, though, these muscles tend to switch off and you start to get some fatty infiltrates. So in that population, those that have got pain for a period of time, we certainly need to work a little bit harder on getting those muscles activating. But learning how to lift and actually activating those muscles before you're lifting a big patient will actually help to sort of prevent injury as well. So it's not switching on all your six-pack muscles. It's more just kind of working on those deeper muscles. So a pelvic floor contraction is a really good way to start. So before you go to lift, you kind of sort of pre-activate, and then you're just going to get your back in sort of a better position to lift. You always hear people saying, bend your knees. That's fantastic. Trying to put as least load through your lumbar spine in a flexed position is obviously ideal. So if you can sort of take that load through your legs is great. Now, I'm not saying don't bend your back, because our backs actually are designed to bend. And when we don't bend our back is when, when we've got this fear around bending our back. That's quite often when we get, sort of some further issues as well. So I guess, trying not to bend your back under load, but feeling like it's safe to bend your back at other times is great. And if you are going to lift something heavily, just sort of pre-activate and sort of lift your pelvic floor before you go to move something.
Okay. This is all, it keeps going back to prevention and, how we can stop these sort of things and decrease our risk factor, which is great. So if somebody does have an injury, and needs treatment, what sort of treatment are you looking at, say, for lower back pain, as well as some of these other common injuries that we've seen? What's your angle? How do you go about rehabilitating people?
Yeah, I guess, as the students would sort of know, I guess you get the most information from your subjective and your history. So, your students would be learning, to talk to the patient. So ask them exactly what happened, what medications, previous history, previous injuries, all of those things. And that kind of helps to build the story. So we do the exact same. So, the most important thing that we do is get a really thorough history and subjective, because that gives us clues into, is it an acute injury injury? Was there a mechanism? Did something happen? Or is it one of these sort of progressive overload type injuries? And again, every patient's different. That's the great part of our job, is that no two stories are the same. So every patient that comes in will have a different set of beliefs, whether it be because they've had a previous injury before, or their parents might have had a similar injury, so they might already have these preconceived ideas about how their injury is going to affect them, or what's going to be actually helpful for them. So we kind of start there, and then again, it kind of just depends. Every injury is different. If we're talking sort of low back pain specifically, I guess, we have a look at, how they're moving. Is there any areas that look like they're sort of stiff or guarded? I don't know if you've ever had low back pain yourself. Sometimes with the acute things, you might have a pain in sort of one area, and then it sort of feels like it spreads, or then it might kind of take up sort of all of your lower back, or it might start on one side and then it goes over to the other side. And that can be sort of the body's natural way of sort of protecting itself. So we kind of have a look at that, and we'll have a look at how the lumbar spine's moving. If an area of that is looking like it's stiff or it's not moving well, we might choose to sort of mobilise or sort of do some manual therapy to try and encourage that normal pain-free movement. And again, sort of get going through with the patient on how to sort of then exercise or encourage normal pain-free movement. Quite often it's encouraging sort of pain-free bending in a way that's going to kind of decrease those big muscles, switch them off, and then switch those little ones on that I was talking about before. So again, it kind of just depends. If something's stiff and it's not moving, we quite often sort of mobilise it. If it's moving too much, it's more likely then we need to sort of support that area. So that's when we kind of go more, okay, how do we get those stabilising muscles working a little bit better? So then it's kind of more the exercise sort of base. But most often an active approach to your own injury or rehab is best.
Yeah. All right. And in your experience, does treatment, is it generally ongoing? Are people, obviously injury is a quite a focused treatment period. You said before 4 to 6 weeks to rehabilitate, depending obviously on the severity. But do a lot of people in this kind of line of work, do they come and see a physio? Would they benefit in seeing a physio sort of ongoing?
Yeah. So again, with those acute injuries, you're right. So most sort of tissue healing sort of occurs within that 4 to 6 weeks. Say if we talk specifically with an ankle sprain, so we know we get ligament remodeling, and that pathology sort of lasts about sort of that 4 to 6 week mark. Not saying that that ankle's going to be sore and swollen for that period of time. We can certainly improve things a lot quicker. Again, bone healing, that's a different kettle of fish again. If it's an acute fracture or something like that, you need sort of a period of time, so usually that's sort of 6 to 8 weeks for bone callus formation, but then it's addressing sort of those other factors. So if you're having to be immobilised for a period of time, whether it be in a moon boot or in a cast, your muscles atrophy, and you have to kind of work up sort of those muscles in and around that area again. With back pain, most episodes don't last that long. If you don't have things like nerve pain as well, if you're not getting pain down into your leg, it's usually about that 6 week mark from feeling an acute episode to then feeling pretty much back to normal. Having said that though, we can sort of certainly make some changes in that time. And I guess the most important thing is not only sort of dealing with that acute episode, but then, trying to prevent things in the future. So, some patients they might come in every, 4 to 6 weeks if they've got a little bit of a niggle, or they might do some supervised exercise. We know that people are more compliant if they actually exercise with supervision. So it doesn't matter what kind of exercise you do, as long as you're doing it regularly. So we do have some that come on a regular basis. But I guess the paramedics that I'm thinking of, I've got a bit of a mixed bag. Some that will just come, when there's actually an injury occurring, and we try and impart all of our wisdom then as well in trying to get them doing things to prevent further episodes. But I do have a couple that sort of come in just every now and again.
Cool. What I'd love to go is just to hear about your best recommendations to prevent injuries and enjoy a long, healthy healthcare career.
Yeah, definitely. I guess healthcare workers can be a little bit challenging because it's in our DNA to put the patient first, and we're all guilty of it.
Great point. Yes.
Yeah. So we end up doing our career because we enjoy treating people and we enjoy helping people. So that's kind of why we choose this sort of area of work. Paramedics, again, are the same. If you've got a really unwell patient, you're going to do whatever it is in your power to help that patient. And I guess in terms of preventing injury, it's the D in the doctor's A, B, C, D that I know that all you guys get taught because you guys teach us that part. So, the D is obviously the danger. And I guess typically you think of, is there a fallen power line or is there, a traffic incident? So do you need to sort of mitigate that risk by actually, putting out cones or having someone stop traffic or whatever it might be? I guess probably not thinking about the danger to yourself and your body position. I know that you would have done your CPR every year. CPR is hard. And, if there is the opportunity for you to sort of move your body into a better position, definitely do that because you may be there for a period of time. You might be with a patient for sort of 30 minutes in one spot. So if you, instead of bending forward to sort of assess that patient and be there, can you kneel, can you sit, can you kind of get your body into a better position? So that's definitely sort of one thing is kind of just thinking about your body position. Same with before how we did talk about sort of that sort of pre-activation when you're going to sort of move or lift a patient and getting them, if they're able, to sort of help you as much as they can. I completely agree with what you said. So prevention is definitely the best form of cure. Trying to avoid those prolonged positions, that's definitely another key thing for injury prevention. And again, just keeping active. So, we know that the more active you are, sort of the better you're going to go. If you've got sort of a baseline level of fitness, that's going to definitely decrease the likelihood of you sort of getting an injury as well. Also with the equipment, so like you guys have those fancy stretchers, the striker stretchers. A lot of them are semi-automatic or completely automatic. So if you can utilise those, use the equipment to the best of your ability as opposed to trying to do everything by hand. That's a good thing about this day and age is that we do have the equipment to actually sort of use. Yeah.
So fitness, is there any type of exercise that you've found most benefit from for your patients?
Again, it kind of just depends on the patient's interest. Obviously, like from a cardiovascular point of view, there definitely needs to be that cardiovascular portion of fitness. So whether that be, walking, running, swimming, cycling. So you're actually just getting sort of that general baseline of fitness where you sort of get your heart rate elevated and it stays elevated for a period of time. So that's certainly helpful. And with weight management, that's really important. I guess from a rehab point of view, for those that are getting sort of lumbar spine pain or having sort of episodes of lumbar spine pain, we do sort of focus on, those sort of deep tummy muscles and so the pelvic floor, those type of muscles to actually try and help to support the back. Things like, side bridges and pelvic floor activation and try to kind of having like an overall sort of back strengthening program can be certainly helpful in those instances.
Are we talking Pilates here? Or are we talking weights or?
Oh, again, it depends on the patient. So, any exercise is good exercise as long as it's done supervised and with a really good program set out. So we use a combination of those things. We do have Pilates at most of our clinics as well. And that is a great way of exercising, simply because, quite often you're back supported on the reformer. So, that is an excellent way to exercise, especially those people that have had pain for a period of time. But again, that's not the only answer. Definitely, body weight, can be a great form of weights. And COVID was another great example of trying to just sort of think outside the box and give patients, more options when gyms weren't available. Again, gyms are great just to add that extra load of resistance, but that's not for everyone. So that's where that subjective comes into play, and it's kind of trying to pick the best thing for the patient so that they're going to be able to sort of implement it into their lifestyle.
Are there any sort of exercises that you would say, look, this is something that anyone can sort of benefit from, do at home, strengthening whatever it be, the core, or is there anything that people can kind of, as a result of listening today, to kind of implement into their daily, weekly regime?
Yeah, definitely. So, I always sort of think about the pelvic floor, like probably my sort of Pilates background as well. That is a really good muscle to start to activate. And again, to think about when you actually are going to do anything heavy, like move something or lift something heavily. So just that gentle sort of pelvic floor activation. I guess some males may not have heard of that before, but males also have a pelvic floor. Usually, it kind of comes up when people have babies because, there's obviously a baby sitting on their pelvic floor for 9 months.
Yep.
So quite often that's when you hear women actually doing pelvic floor type exercises. But again, everyone's got a pelvic floor, and pre-activating that quite often does get, your transverse abdominis and your multifidus working as well. So that's a great one just to actually start, just to sort of know your pelvic floor and actually start activating that. And that's the muscle that basically stops the stream of urine. So if you're not sure what it is, that's an easy way just to check that if you can do it. We don't say to do that all the time, but if you're not sure how to actually activate, that's just a good option just to kind of get that started.
Yeah.
And then I like side bridges, side planks. You don't need any equipment for that. So just sort of going up onto your elbow, legs out straight and trying to hold that. And there is some good evidence that holding a side bridge for 90 seconds, which feels like an eternity, you have a low likelihood of actually sort of developing low back pain or having another episode of low back pain. And that's also if the side bridge hold time is sort of within 10 seconds each side. So if there's asymmetry or one side's a lot stronger than the other, that obviously can increase your likelihood as well. So that's just a really nice one, and people can start off doing 30-second holds and build themselves up. Cool. In terms of, sort of getting your quadriceps or sort of the thigh muscles nice and strong, I quite like wall squats. So, instead of doing a squat underneath a bar or a squat rack, you actually sort of lean against the wall. Maybe you have like a Swiss ball or a foam roller behind you, walking your feet out and then actually squatting. So your back actually stays nice and upright. However, you've actually got quite a bit of load through your legs. So again, kind of training your legs so that when you do go to squat and lift a patient, you kind of have that little bit of extra strength through there. So there's some easy ones.
These are things that people can do pretty much every day at home without equipment.
Yep, exactly.
Yeah, that's great. Really good. So just to summarise, we talked about pelvic floor.
Yep.
Exercises. We talked about side planks.
Yep.
Right?
Yep, and wall squats.
Awesome.
Yeah.
And I'm sure people wanted more instruction, they could probably YouTube it and...
Yeah. or go see your local physio.
Why not do that?
That's probably, again, more of a... I guess if people are having issues or they're having even little niggles, I guess the best thing to do is get onto it early. So go and see a healthcare professional, and that way they'll give you the best guidance. And it might be a physio, it might be an exercise physiologist, but actually just going to see someone and going, okay, this is my concern, or I'm about to start this new career, what can I do? And again, it'll just be really tailored to be specific to them. So get on top of things early. But definitely sort of prevention's the best form of cure. Try and keep active, try and keep a baseline of cardiovascular fitness and also some strength. Make sure that you get your body in a good position if you've got the opportunity. Avoid prolonged positions and just get up and keep moving.
Okay. Along the lines of prevention now, I'm thinking we've talked about fitness, getting active, strengthening those muscles, and some good exercises. But what about sort of lifting techniques? And it's obviously something that people will likely learn throughout their training and study in healthcare. And then the other thing I was thinking of was if we could have some tips there, the lifting and things, but also the sitting at a desk, the sedentary stuff. We talked about setting up the right way. But can we get a few tips on what that might look like?
Yeah, definitely. So I guess just to touch on the lifting again, so that would be that pre-activation. So make sure that you bend your legs, keep your back relatively straight under load. So pre-activating, so whether it be your pelvic floor, transverse abdominis, however you sort of think about it, before you go to lift, trying to avoid heavy lifting if you can. So that's using the equipment or getting the patient into a better position if they can actually assist. So that's kind of, the lifting side of things. With the workstations, so you want to be sitting comfortably with your feet on the floor. You want a comfortable chair, and you don't have to spend a lot of money on a comfortable chair. It might be as simple as grabbing a rolled up towel and popping that behind your back just to change the position of your back, and doing that for 20 minutes or so, and then taking it out and just kind of altering what you do. If you don't have the opportunity to actually get up and stand up, or, walk around the office, go to the printer or whatever it might be, actually just standing, you can just stand up on the spot, hands behind your back and just do some repeated sort of extensions, so just some leaning back, or in the chair, just doing some pelvic rocks. So sitting on your sitting bones and then kind of sitting, slumped, what your mother would say is bad posture, and then sitting right up high on your sitting bones. So all you're doing there, you're actually sort of still moving your back, but without actually getting up and having to move around if you don't have the opportunity. I'm thinking more if you're stuck in an ambulance for a period of time.
Yeah, for sure. Okay, that's great.
having a play there.
Excellent. Okay, and would you do these sort of things maybe every half an hour or?
Yeah, ideally. Yeah. So again, our backs don't like being in the one position for a long period of time. So every sort of 20 minutes, half an hour, most of us will have the opportunity to kind of set an alarm, whether it be on your phone or on your computer, even just set something just to remind you to get up, because sometimes when you're really engrossed in something, you might not think about it. Yeah.
Standing desks, are they a good thing or a bad thing? Or
yeah, again, prolonged positions. So you're not going to be able to use it all day. So you're not going to be able to stand up and stand all day, because then you'll get sore in other areas. The Very desks are great. That's not a brand name, but just the ones the variable height desks, I guess. So the ones that you can actually put down, sit for a period of time, and then actually stand up. Yeah. Most offices, will have a bit of a combination of both. Or if you don't have access to one of those, it doesn't matter. But as long as you then sort of just make sure that you just physically just get up yourself and just stand, have a bit of a walk around. You could stand there and do some star jumps and do some squats at your desk. To stand there going up and down on your tippy toes, just doing some calf raises just while you're sort of waiting for an email to send or something like that. So there's lots of different options.
Cool.
Yeah.
That's really good. And okay, now for the injuries, the RSI, the texting thumb or any of those, is there any sort of prevention techniques that you know of that could prevent those sort of injuries, as opposed to your lower back and things like that?
I guess too, just making sure that you do have a good setup. So if you are starting to get some symptoms, can you change where your mouse is located? Can you change where your keyboard is? Can you bring it closer? Perhaps a different brand or a different type might be more comfortable for you. You might need sort of a gel strip just to kind of rest your hands on, just to make it that little bit more comfortable as well. But again, it all comes back to kind of decreasing prolonged positions. So if you can give your hands a break, just move them around a little bit, give them a bit of a stretch, get up, have a walk around, and actually just get out of the sitting, because it's not only your lower back but also sort of your neck and shoulders and arms that can get quite sore from being sitting for a period of time.
Excellent. Well, that's a really rounded approach. I think that's really, really helpful to be able to sort of get, because like we said before, you don't think about an emergency care, a paramedic, emergency care professional sitting for a lot of time. We see them in action on TV, and we think about those maybe acute injury events and the lifting and all that sort of stuff. But it's a career that's got quite a diverse variety of different positions and potential risks.
Yeah, definitely. And I guess even sort of some of the event coverage that you guys will probably end up doing, fingers crossed that you're not actually too busy, and you may just be sitting sort of in the ambulance or just sitting sort of at a first aid station for a period of time, waiting for patients or just observing, just making sure that nothing acute happens. So in that downtime, again, same thing, can you be up and walking around, or can you be doing something as opposed to staying still?
Excellent. So we've talked a lot about how we can support our own health. But Erin, you've also got experience, obviously, in being a first responder in a physio sense. And what I want to go to now is that now, how can we as healthcare workers, emergency workers, paramedics, how can we better support what you guys do when we are faced with acute injuries and we're treating patients in that, the first response sense? What are some of the techniques and things we can improve the outcome for these injuries?
Yeah, definitely. So I guess there's kind of two parts to that. I guess in my experience, I've also been the first contact practitioner at a sporting event. So quite often the physios are there on the sideline for the local footy club, and quite often so we sort of get to the patient first, and then those ones that might have a significant injury like a compound fracture or a fracture dislocation, we sort of, we'll get them into sort of an area of safety, trying to mobilise it the best that we can. And then it's definitely getting the paramedics involved to actually transport the patient. So from that sense, we basically just give them the best history that we can. So this is exactly what happened. This is the area that's injured. It has happened that we've had some bad concussions. So if they've lost consciousness, for how long for, kind of just giving the paramedics all that information. So when they sort of get to us, I guess, it works really well if we've got a really clear history, and then we basically hand over to them and we just get out of the way then, because, that's where you guys take over, and that's definitely your area of expertise if that needs to, that patient needs to be transported safely, given some pain relief or whatever it might be. In the clinic, actually, I've only sort of, fortunately, I think we've probably had to call a couple of ambulances. I've only fortunately had to call one in my time. So I had a patient who actually she'd already been to hospital, but she came to me about a week later after she'd had a slip and a fall in a bathroom.
Okay.
So she had a sort of concussion, a head injury, and I'd known this patient for a period of time, but her level of consciousness had decreased and she was getting quite fatigued and tired. She was slurring her speech. So all of these sort of warning flags that you kind of think, oh my gosh, there's something bad going on. So my experience then was the ambulance, again, just up the road from GCUH, they were lights and sirens, and they were there within sort of 5 minutes just to take over, because we just thought she might have had a bleed.
This is a week after the actual event, the injury event.
Yeah, and then she came to me because she's like, oh, my neck's still a little bit sore, but then just sort of on further questioning, I was like, oh, something's just not quite right here. So fortunately, that doesn't happen a lot in a private setting, but it is good when just to have the ambulance there and so quickly as well. I guess on the flip side, so that's sort of when we're there and then the ambulance gets there after. On the flip side, if the ambulance kind of are the first contact practitioners, and then that patient may or may not go to hospital, and then we'll see them perhaps in the clinic, it might be a week or two later. I guess, you guys are fantastic at that thing. It's that sort of early immobilization. I'm sort of more thinking, the high level sort of shoulder injuries or ankle injuries or dislocations or subluxations or ACLs or, all the common sporting ones that we get. It's that sort of early intervention. So that early immobilization, good sort of early pain relief, simple analgesia, getting them to the hospital, getting them sort of assessed and any images that they need, immobilizing it, giving the patients kind of the education in and around what they can and can't do early days. And then quite often they'll come in and see us, whether it be a day or two later, to kind of then start their rehab sort of after they've had sort of the initial management. Yeah.
So in a real general sense, immobilization is absolutely, the number one critical thing in first response, and then from there, and obviously until hospitalisation, treatment, whatever can be done. So what are some of the like even as a first responder, some people may be going into some employment or volunteer work as a first responder, immobilising somebody who's just had an injury, child, they don't take directions at the best of times, but in an injury sense, what are some of the ways in which we can just better mobilise somebody who's just suffered a
guess you guys would be sort of better at that stuff than us, but quite often, can you immobilise, can you splint to another limb, for example? So say it's a lower limb injury, can you splint it to the other leg so that they just don't have the option? If it's a shoulder or an arm, can you sort of sling it or wrap it to their body so they actually just can't move their arm at all? I guess too, education, so getting sort of people around them, having kind of a cool head so that you're not panicking. It might be quite often it's trying to calm the parents down as well if it is a young child, kind of just getting everyone settled, seated or lying down if the patient needs to, and then just educating, okay, this is what it is, this is what's going to happen now. It can quite often be the fear of the unknown, but if it's like, okay, well, we think you've done this, we need to keep still until we can get you to the hospital, we need to image it, and then we need to go further from there. So just having a cool head and actually just probably explaining to either parents or the patient would probably be one of the best things to do.
Sounds like less is more in a sense.
That's it.
With these sort of injuries, we can often feel like, I've got all this knowledge and sure there's something we can do, but the best thing you can do is often educate, calm people down, minimise movement.
That's it, yeah. So, and again, it's people management at the end of the day. With those acute things, you got to just manage people. And I do know that, speaking to some of the team here, crowd management, quite often, I know that some have done, some coverage in at Surface and things like that when there's alcohol involved, and it might be, the friends or whatever, or there might be a fight or something, and it might be kind of just trying to dissipate the crowd and actually just get your patient safe, but actually just getting everything else around them away.
Right. So is there any further advice that you'd want to give people listening here? So maybe even if they have a niggle or an injury, what do they do? Can they learn what they need to? Can they sort of treat themselves at home, Googling or whatever, but, or should they really go and see somebody?
Yeah, definitely. So I guess, there is a lot of information out there, but ideally, if someone's got a niggle or they've got an acute injury, getting in and actually seeing a healthcare professional, so your local physiotherapist, would definitely be a first point of call. My advice would be, again, that way you can get the correct advice for you, specific to your set of circumstances, and that might be some advice in and around things that you can and can't do, or some rehab advice, some exercise advice, but at least then it's specific to their own situation. So if anyone does have any injuries or concerns, go and talk to your local physio.
And on that point, I think I only just recently realised what a role of an exercise physiologist could do to, you kind of heard of the PT, the personal trainer, at this level, the exercise level, but I'd never really explored, and I have recently seen an exercise physiologist, didn't know they really existed. And I think that could potentially be a really great combo, a physio and an EP to assist with the right
definitely.
exercise program as well.
Yeah, most of our clinics have an EP working with them, or some have multiple. So again, we work sort of alongside each other, and I guess it's that sort of overall multidisciplinary team. So most of us will have a podiatrist, an ex-phys, your massage therapist. We might have your psychologists that come in as well. So it's kind of that whole team sort of environment. Definitely the EPs are excellent. So they go to uni for 4 to 5 years as well. Basically just learning about exercise prescription. So not only injury, but also for some of those chronic health conditions. And I guess too, that's another good point, having the paramedic students know that EPs are available, and patients that and again, correct me if I'm generalising, but I think the most common call out to an ambulance would basically be for a cardiovascular event. So that these patients quite often are obese, they're overweight, they might have other comorbidities such as diabetes, some of their lung conditions. So getting in with an EP, they're experienced in those chronic health conditions. So their wealth of knowledge is just phenomenal about those chronic health conditions. So your cardiovascular diseases, your diabetes, and they can definitely sort of lead people in the right direction, because again, it comes back to that prevention. Can we prevent people from having cardiovascular events, and exercise and good management is definitely part of that. So yeah, we're lucky we've got a great EP at our clinic, and most do. So we work really well with the EPs.
And in terms of training, qualifications, knowledge, they're a bit of a step above your PT that you'd get at a gym or whatever.
Certainly, yes,
right.
Yeah. So again, there's some great PTs out there. Don't get me wrong, but I guess just the level of training for a PT compared to an exercise physiologist is a bit different. So some courses for PT might only be like a 12-week course, whereas an ex-phys is a 4-year university degree. And sometimes and then some. So yeah, so it is just that little bit different. Yeah.
And is an EP somebody you could go to for prevention if you don't have an injury?
Yeah, absolutely.
But you want to get sort of more prescribed kind of exercise program. Is that correct?
Yeah, absolutely.
Right.
And I guess too, physios and EPs are first contact practitioners. You don't have to have a referral to go and see a physio or an EP.
Yep.
You don't necessarily need to go to your GP first, and some patients do, and some may get some back from Medicare by doing that pathway, but not necessarily. So you actually can sort of present to your physio clinic and just sort of book in with your EP or your physio and sort of have a chat to them and go from there. And quite often, we will work with each other, and it might be getting the GP involved as well, and kind of having that sort of team approach to management of a person.
Great. Fantastic. Amazing information, Erin. It's been really, really good to chat with you. Is there, I mean, if you're on the Gold Coast, certainly Allsports Physio.
Yep.
It sounds like a great place to go. Just talking to you now, but also getting that whole collaborative approach to your physical health for not only prevention, but also treatment. So can people follow you guys on any sort of social media platform? Do you have information out there on the web?
Yeah, definitely. So all of those. So allsportsphysio.com.au. So we've basically got website. We've got a whole range of clinics located sort of South East Queensland and now beyond. So we're part of a bigger group, which is called the Healthier Group. So we're kind of affiliated with some optometry, some OTs, podiatry as well. So we've kind of got this great big team. We've got so many different locations of our physios and our other allied health. You can certainly go on there, have a look where your closest is. You can book online too. We're very tech savvy in that way.
Cool.
We do have Instagram and Facebook as well. If you want a bit more information, you can certainly kind of investigate through all of those different avenues.
Wonderful. Will do. Thanks again, Erin.
My pleasure.
It's been awesome. Now, before you go, I have some quick fire questions. All right? Now, don't get nervous. Nothing too heavy. Okay.
Yep.
All right. But think of the first thing that comes to mind and in 10, 20 words or less.
Yep.
Okay. All right. So what's your personal favourite form of exercise?
Swimming, running and Pilates. They're sort of my three that I do. I can't pick a favourite. I like all of them.
Swimming, running. Awesome. Okay. Your favourite local takeaway?
Pizza.
Pizza?
Yep.
Is there a local best joint to go to? Or?
Oh, Sandy's Pizza. I live in Pacific Pines. Their pesto chicken and avocado pizza is next level. It's so good.
Get on to Sandy's, guys. I don't think they deliver nationally, but, what's your pet peeve?
Messiness. Yeah, I've got borderline OCD. When there's stuff that's messy, that just does my head in. Yeah, whether it be the clinic or at home.
Don't look beyond the camera frame.
Yeah.
Right? Strangest day on the job?
Being involved, I guess, in the footy grand finals. So I guess not strange, but it's just that different type of job. It's not in the clinic; you're actually on the field. And I was lucky enough to be associated with the team, and we won 2 premierships back to back. So that was really cool. Yeah.
Awesome. Most rewarding day on the job?
We were talking about this recently, actually, and we had a patient come in and she actually said that it looks like everyone that works here loves what they do and that you guys just have a really nice team. And so we were sort of talking about that. We had a team meeting that afternoon anyway, and that was just so rewarding just for patients to actually see how much we actually enjoy what we do. So we've got a great team where we are and we all love what we do, so we're so lucky.
Sounds amazing. That's awesome. Okay. Your most common advice to people in 10 words or less?
Keep active and move your body. Active and move your... Yeah, there you go. That's 6.
That's under. Even better. Erin, it's been a pleasure. Thank you so much.
No, my pleasure. Thanks for having me, Ben.